Hello, and thank you for joining us tonight for our free webinar, Huatuojiaji Points and Spinal Offsets, a Zang Fu Perspective, featuring Matt Callison and Brian Lau from the Sports Medicine Acupuncture Certification Program. My name is Jeff Bloom, Education Marketing Manager here at L.A.C. OMS. For over 40 years, L.A.C. OMS has been striving to promote the growth of the acupuncture industry by providing quality products, great prices, and the best customer service, as well as supporting the many schools and continuing education efforts available. With our free webinar series, we intend to provide free educational opportunities taught by some of our industry's most renowned practitioners and educators. I would like to take a moment to acclimate you to the webinar room. To the right of the video screen, you will see 3 tabs: Chat, Questions, and Polls. To chat with other attendees or to communicate any technical difficulties, please use the Chat tab. For questions of our guest speakers, please make sure to use the Questions tab so we see it after the lecture. And please note that each webinar is recorded, and immediately following the conclusion, you will all receive an email with a link to view the video on demand. You may always visit our blog and use the free webinar tag to find all of our previously recorded events. From sports acupuncture to neuroscience to Chinese herbs, you'll find something interesting for every practitioner on the L.A.C. OMS blog. Now for our featured speakers. Matt Callison's unique ability to blend Chinese medicine with sports medicine for almost 30 years is demonstrated by his excellent reputation. This is particularly evident in his educational program, the Sports Medicine Acupuncture Certification Program, which is attended by acupuncturists worldwide. He has over 20 years of experience in cadaver dissection that has helped him further broaden and deepen his educational program for the acupuncturist. And Brian Lau is certified in both sports medicine acupuncture and structural integration. He has been on faculty since 2013 with the Sports Medicine Acupuncture Certification Program, where he teaches anatomy and physiology, palpation assessment, and treatment of the channel sinews. Please join me in welcoming Matt and Brian.
Thank you.
Thank you, Jeff. Really appreciate that. Thank you, L.A.C. OMS, for having us. Well, Brian, what do you say? Do you want to jump right into the first slide and I'll do a little intro to it? And
yeah, sounds good. I'll go ahead and share the presentation. Give me a second.
So you guys, thanks very much for joining us and good evening. So tonight's discussion of the Huatuojiaji Points and Spinal Offsets, a Zang Fu Perspective, is something that we've been using clinically for well over 20 years. It's looking at the patient from a posterior view and looking at their spine and trying to be able to match their spinal bends and where it actually comes to the midline with their Zang Fu complaint. So in this particular presentation, we're going to try to diagnose some spinal bends, what Huatuojiaji points to be able to treat, when to be able to treat deep on both sides of the spine with the Huatuojiaji points, when to be able to treat one side deep and also one side superficial, and to get an idea of how many Huatuojiaji points to be able to treat and when to be able to treat them. So we're also going to be discussing about organ symptoms turning into a facilitated segment where the spine, the myofascial tissue at the spinal segment, and also the organ itself becomes this perpetuating cycle of pathology. And to be able to treat the Huatuojiaji points, the back shu points, and the front mu points, in addition to Chinese herbs and exercises and such, to be able to break that perpetuating cycle of a facilitated segment. So we've got a lot to cover, and before we jump right into the Huatuojiaji points, Brian, do you want to say anything, or should we go right in?
No, why don't we jump right in? You can see the presentation now, yeah?
Yes.
Cool, okay.
So let's go to the next slide. So the Huatuojiaji points, as we know, is going to be from 0.5 to 1 sun lateral to the lower border of the spinous process. Now, we bring the Huatuojiaji points all the way up to C1. In most textbooks that you see, they'll actually be ending at T1. But whenever there's going to be a dorsal primary rami nerve, which happens in the cervical vertebrae as well, which is part of, in our mind, which defines the Huatuojiaji points, is when there is a dorsal primary nerve, which we'll be discussing that a little bit more in a second. So we bring our Huatuojiaji points all the way up to C1. So from C1 all the way down to L5. And when Huatuo himself, the famous physician, was actually practicing almost 2,000 years ago, would he have ever thought we would still be discussing his work today? That's a pretty amazing thing to actually be thinking about what an incredible physician and his work and how important it is to not only to traditional Chinese medicine practitioners, but also to medical acupuncturists that are treating the Huatuojiaji points as well. So just wanted to be able to give credit to the famous Huatuo physician and his insightful work. So let's go to the next slide if we could. Now, the dorsal primary nerve is so important, and this is really what helps us define the Huatuojiaji points. The dorsal primary nerve is a posterior branch, and Brian, if you could be able to take the arrow and just show this as we're going, is a posterior branch off of that spinal nerve. There's a medial branch that innervates the tissue of the deep paraspinal muscles all the way up to the skin of the Huatuojiaji point region. In addition, there's a lateral branch of this dorsal primary that innervates the inner bladder line and also innervates the musculature of the outer bladder line. So therefore, your Huatuojiaji points, your inner bladder points, your back shu points, and the outer bladder points are all musculomotor points. Now, the dorsal primary rami is a posterior branch of the spinal nerve that innervates the tissues of the dumi, which will be the spinous ligaments, the supraspinous ligament and the interspinous ligament. Also the Huatuojiaji points, which will be specifically the deep paraspinal muscles. We're going to spend a little bit of time talking about these deep paraspinal muscles. The deep paraspinal muscles are also called the transverso spinalis muscle group. These are very, very important because the depth of these is where we want the acupuncture needle to get to in order to be able to affect each individual vertebra, especially when that spinal segment is directly related to organ dysfunction. So we talked about the inner and the outer bladder line as well, that dorsal primary rami innervates the facet joints. So let's go into the next slide, please. Now looking at the thoracic region, which is going to be innervating the middle jowl, lower jowl, upper jowl. The intercostal nerve is an anterior branch of the thoracic spinal nerve that innervates all front mu points. So let's take a look at the medial branch of the dorsal primary rami, if we could, Brian. Yep. So then we've got, follow it back down, and then we've got the lateral branch of the dorsal primary rami. Okay, good. And then let's follow that back down to the spinal nerve. And then you got an anterior branch that goes around the thoracic cage and then innervates the musculature in the front of the body, which would be your front mu point. This is the reason why we have our front mu points and back shu points on the same level line, because of that spinal nerve. Let's go back to where the spinal nerve exits. Right, so then now, if we go posterior, dorsal primary rami, but look at it anterior now. If we go anterior, you've got your branches then go to the sympathetic ganglion and the sympathetic trunk that directly innervate into the organs themselves. This is why Huatuo was so incredibly brilliant, is stimulating the Huatuojiaji points will be a direct communication through the sympathetic ganglion and then into that organ itself. In addition, the organ receptors themselves will communicate through that sympathetic ganglion and reflect its pathology or its health within the outer bladder line, inner bladder line, and also the Huatuojiaji points.
And the front mu points.
And the front mu points, yeah, thank you. All right, so let's get into this transverse spinalis group. We're going to talk about three particular muscle groups here within the transverse spinalis that are going to be very important to be able to help align individual vertebrae. So the most superficial, well, first of all, the transversal spinalis muscle group is different than the erector spinae muscle group. We know the erector spinae is going to be the iliocostalis and the longissimus and the spinalis. And those are going to be actually moving the spine itself and moving the trunk. Whereas the transversal spinalis muscle group is going to be deeper than the erector spinae. It attaches between the transverse process and the spinous process. So they're really quite narrow and small there. So the spinalis muscle group will be the most superficial of this transversal spinalis group, innervated by the Huatuojiaji points, dorsal primary rami nerve, and affected with your deep needling. If you look at the spinalis, you can see that it attaches the lower attachments at the transverse process, and the upper attachment is going to be in the superior border of the spinous process. Now, they usually range about 6 segments. Some books will say 5 segments, 5 to 7 segments. So it differs from human to human, but normally it's around 6 segments what the origin and insertion to the semispinalis group will be affecting. So let's go to the next one. So if we take the semispinalis off, next we have the multifidus. Now the multifidus is going to be ranging between 3 and 6 vertebral levels. The multifidus, you can see, attaches to the transverse process, but then now it's going to be attaching a little bit lower than the semispinalis capitis or cervicis. It's going to be attaching on the lateral aspect of the spinous process. So you can see then, if you have a multifidus here on this image on the left, and we had a multifidus on the right, the nice even pull between left and right sides of the multifidus will help to align each one of those vertebrae. Same thing with the semispinalis, cervicis, and thoracis. So the even pull is really what we want to be looking at here. Let's go to the next deeper layer. So the next slide, please. So we take the multifidus off now. Now we've got the deeper layer. So you got your rotator, cervicis, and thoracis. Again, affected by your needling at the Huatuojiaji points. By needling these particular muscles within the transversal spinalis group, it helps to affect vertebrae that are subluxed, offset, fixated, especially when there's a side bend that actually is causing a fixation or a subluxation. So the depth of the Huatuojiaji point is going to be really important. We're trying to affect this particular group. This particular group, the motor entry points, are at the Huatuojiaji point. So you can make a significant change within these muscles by needling the Huatuojiaji points. We like to needle the Huatuojiaji points more perpendicular than oblique, and we'll have that discussion in a little bit about that. Now you've got the rotator, cervicis, and thoracis. You've got the longus, and also you've got the brevis. Now the longest is going to be expanding 1 or 2 vertebrae above. They attach from the transverse process to a lower aspect of the spinous process because they're the deepest. They're deeper underneath that multifidi. And then you've got the brevis, which is attaching from the transverse process then to the lamina. Again, these muscles are affecting individual vertebrae. Collectively, they can be able to help to extend and rotate the vertebrae, but they also have a tensional pull between left and right sides to keep the vertebrae aligned. When vertebrae are going to be offset or fixated, then you're going to have excess and deficiencies on each side that we're going to be talking about in a little bit. Now, look at this last part, the second paragraph, if you would. The rotator's muscles have a high density of proprioceptors and have been found to significantly contribute to postural control. Now, if you go into Google Scholar and you actually type in transversal spinalis muscle group and proprioception, you'll see quite a few articles that actually talk about how the transversal spinalis are primary with spinal stability, proprioception of the spine itself. That's going to be compared to the rector spinae that's actually going to be moving in the gross movements. So this transversal spinalis muscle group, very important to needle the Huatuojiaji points in order to be able to change proprioception. All right, so what's the next slide there, B? Now it's interesting about the trajectory of the Dumai. This is something that we've been lecturing for about the last 20 years or so, looking at the different channels of the Dumai and how significant they are when you're looking at the dorsal primary rami. So if you look at figure A, you've got the third branch of the Dumai. And it's interesting how they map that out. Now, this is thousands of years ago when they're mapping this out, how it looks like it could be the multifidus fibers or something really quite similar to that. Because our founding fathers also did dissection, they may have actually seen these transversal spinalis muscles and thought this would be part of the Dumai vessel. If you look at the connecting low branch of the Dumai, that looks kind of similar to the semispinalis cervicis and the semispinalis thoracis. So therefore, when we're treating a spinal offset, spinal bend, a vertebral fixation, a vertebral subluxation, not only can we treat the transversal spinalis muscles on both left and right side to help change excess and deficiencies, but if we also needle the DUMI at that section or selected points along that section, we're affecting the dorsoprimary rami because it innervates those ligaments. And we're then linking DUMI vessel chi with the Huatuojiajis. They complement one another when you're treating the Huatuojiaji points and also the DUMI points. All right, so this is looking at the spine when it's quite normal. Let's look at force couples. Now, the force couple relationships are the agonist and antagonist relationships. It refers to the group of muscles that function together by either co-contracting to help stabilize a joint or to oppose one another that allows for controlled motion of the joint. So again, just want to really reiterate the transversal spinalis muscles here on this movie. You can see the multifidi on the left and the semispinalis thoracis on the right as being opposing muscle groups in order to be able to rotate the vertebra. So therefore, when you have, again, a subluxation, a vertebral fixation, a side bend leading to a subluxation, you'll have excess and deficiencies within these transversal spinalis muscle groups. So we talked about having a balanced pull between left and right sides and how important that's going to be. Let's now talk about these imbalances that can occur and then link that with what Huatuojiaji points to be able to treat. Brian, you want to take it over?
Sure. All right, so we have a couple images here, and we're going to discuss some aspects of spinal offsets. So the spinal offsets can be perpetuating Zang Fu problem because it's going to reflect, just how Matt was discussing, it's going to reflect that neurological segment. So if you look at the image of the man on the right, he has spinal offsets that you can see in this lower lumbar region, also as we get more into the thoracic region. And there's multiple contributing factors to this. It could be an elevated ilium. He has an elevated ilium, elevated on the left side. So that's going to change the base of support, and then the spine's going to start to adjust to that change of base and support. We see the spinal offsets there. Contributing factors could be functional versus structural scoliosis or spinal bends. The difference, functional would be more muscle held versus structural, which is more bone held. Again, what that means is a muscle held functional scoliosis could be due to muscle imbalances. Maybe the person had a fall and an injury, fell off a horse, and they had some kind of adhesion in the fascial net that came from that, and then the adaptations that came from that. Maybe they were desk workers and they're always shifting their body to one side to reach their mouse or computer screen or be on the phone or whatever. They're using their body in an imbalanced way, and they develop muscle imbalances that lead to a functional scoliosis. Changeable. It's due to the excess and deficiency in the myofascial system. Versus a structural scoliosis, which is going to have more to do with changes in the bone shape. And that's going to be something that can be adjusted to an extent, but it's in their articulating surfaces. It's not going to be fully changeable. So that's what I use the term kind of muscle held versus bone held. To assess for these, we can use a very good test, very simple test, the skyline examination. So if we first of all observe the patient from the back, and we can look for these spinal offsets, and then we have to determine, is this functional or structural? Is this a functional scoliosis or a structural scoliosis? So once we observe the spinal bends, then we're going to have the patient bend forward, and we're going to look to see if there's a change. So with the functional scoliosis, as you add length to the spine by having them bend forward into flexion, that even pull of stretch on those various myofascial structures will start to diminish those spinal bends, and it'll straighten the spine. Whereas in a structural scoliosis, it's going to maintain those those spinal bends. You'll see the rib cage rotating up more on one side. You'll see the asymmetry maintained. So it's a very simple test to be able to screen for functional versus structural scoliosis. A couple things to look for when you're doing that. You want to make sure they have an even hand position. You know, if this hand was hanging down lower, that's going to potentially give you a false read. If one of his knees was bent and the other one is straight, that's going to give you a false read. So you want to have them go down in an even manner, but then you're looking to see if the spine straightens and diminishes that curvature, which would be the functional scoliosis. All right. So interesting aspect, if we have these bends, as Matt was mentioning, we're going to have some excess and deficiency. We're going to have certain structures that are locked into a shortened position, and we're going to have certain structures of these deep paraspinal muscles that are going to be in a locked long position. When you look at the study with the stretch reflexes and EMG studies, there's going to be a difference between these structures. Say, like if we notice this bend here, there's going to be differences in the structures that are shortened on the concave side. Those are going to have a decreased afferent signals, the signals going back to the central nervous system, versus the lengthened, locked long, deep paraspinal side on the convex side of the curve. We're going to have an increase in afferent signals. So the ones on the locked long sides are kind of crying out, communicating to the central nervous system, almost like crying out in distress. Whereas the locked short structures are going to be communicating less to the central nervous system. They're there, they're holding, they've kind of turned off. Their signaling is not going really efficiently back to the nervous system. So we can see that in the thoracic region, we would have a decrease on this right side, on the concave side, an increase of signaling on the convex side. Mm-hmm. That's the most obvious on this, but you also see some aspects of a bend here also. Mm-hmm. Mm-hmm. So interesting to start thinking of needle technique, and we'll get more into needle technique as we go. But if you think of this on the concave side as being more of a excess condition, locked short, you'd want a needle technique that has a little bit more oomph to it, a little bit, maybe a deeper, a signaling that's going to communicate more afferent signals back to the central nervous system versus a technique on the more deficient side, locked long side, where you don't need to, it's already communicating excessively to the central nervous system. So you don't want to have such a strong needle technique on that side.
Hey, Brian, can we go back to that one?
Sure.
Can I say a couple things?
Absolutely.
Okay. In the past, we've had some students a little confused about when we talk about the concave and the convex. And with the concave, as Brian just said, that's going to be more of your excess side, but yet it's communicating less. So it's communicating less because of the stagnation itself, right? Because it's going to be excess. Whereas like Brian was saying before, the lengthened side, it's going to be reporting a lot more information because most injuries occur actually with lengthened tissue. So that's going to be reporting more of the afferent. In addition, if you take a look at this gentleman, hey, Brian, can you look at the lower side bend, the lower right bend? Looks like it's coming back to the midline around T11, T10, T9 region. Yeah, this is something to look for clinically, is when you see a side bend go back to the midline, that's usually a real problem area. There's usually going to be a fixation within that region. There's going to be a subluxation within that region. Associate that side bend going to the midline with the person's Zang Fu symptomology. You'll often see it match. Side bends going to the same level of where the back shoe points are and the innervating spinal segment for that particular organ that the patient's coming in with their chief complaints. For example, this guy had a really bad stomach heat, spleen sheath deficiency, and gallbladder heat. And you can see where the side bend's going right into is really quite level with the back shoe points for the spleen, stomach, and gallbladder. Yeah,
Yeah,
thanks, Pete.
Yeah, sure. There's without getting the spinal mechanics are pretty complicated, but there's a lot of rotational aspect. And when it comes back to the midline, there's a quick change of direction, as it sort of normalizes back to the midline. So those areas of shift between, the bend coming back to the midline and then all of a sudden changing directions, or where it takes off from the midline, either the lower portion or that higher portion. In this case, Matt, you're looking at the lumbar curve that's coming back to the midline around that sort of T10, T11 region. Yeah, so there's a quick kind of a change of movement in the spine there that can sort of really jam the spine up quite a bit.
So patients with upper jowl problems, you will commonly see a side bend then coming back to the midline around T3, T4, T5, T2, T3, T4, T5. So you would look in that region for fixations, subluxations that could be contributing to some of the problems. Yeah, good.
All right, so just a quote we put together to kind of consider the proprioception and the signaling that's happening in the body. So where there's proprioception, there's qi. Where there's a decreased in proprioception, there's a deficient qi. So just kind of something we look at quite a bit in AccuSport and work with, to wake up that proprioception and to balance that proprioception so that the body can communicate properly between these agonist and antagonist structures. All right, so we've talked a little bit about vertebral fixations. And Matt and myself were just mentioning a second ago about how these are frequently going to occur where those spinal bends come back to midline or where they leave the midline. Again, with this previous person where that right spinal bend comes back to the midline, or maybe where it takes off from the midline and starts becoming obvious. Those are places to look for vertebral fixations. But what we're looking at is these rotational components of the vertebra and how they can lock. So let's say this was T8, T9, T10. It could be any vertebra we're looking at, but let's just use an example of T8 through T10. So T8 can rotate on T9. It can rotate to the right where that spinous process would kind of deviate more to the left, or it can rotate back to the left. And we'd see the spinous process come a little bit more to the right side. So I'm using right and left rotation to talk about the front of the vertebra, so which way the front of the vertebra is facing. But it's just in a normal movement, it can rotate on the vertebra below it. So what we could have with a vertebral fixation is that rotation is stuck. It's like a jar, like a mason jar, where that cap is turned too tightly and it's locked. So maybe where that movement occurs on the spine, those facets are locked on one side. So you can kind of see this arrow of this vertebra was stuck in that left rotation and locked down facets. That would be a vertebral fixation. It's not able to come out of that rotational pattern. So then same thing, T9 on T10, etc., is the ability for those vertebrae to move versus them getting stuck into some kind of fixed pattern. So it's kind of a torquing of the vertebra. You can assess that a number of different ways. We'll look at a couple of possibilities, but one simple way is we can use palpation of the Huatuojiaji points. So if we expect a vertebral fixation, especially like, if it's matching that segment of where T8, T9, and T10, and there's some signs of liver disharmony from a TCM perspective, we might look at this region to see if there's vertebral fixations. We can palpate the Huatuojiaji points, and we can feel for excess and deficiency. Because with those torquing, we're going to have a side that's over lengthened and deficient. It's going to be more pliable. It's going to be less rigid versus more on the fixed side where those deep paraspinals are shortened. And in an excess condition, they're going to be much more rigid, much more ropey, kind of grainy, fibrous. So we can palpate in that region of the Huatuos, right and left, the T8, T9, T10, looking for those excess and deficiencies in that region. That would be indicative of vertebral fixation. So you just want to, feel sort of an even tone between those two sides. Anything to add to that, Matt?
Yeah, just a little bit. So the short and locked short muscle, thinking that is going to be excess, that is keeping the vertebrae locked and that facet joint locked. So it's preventing the vertebra to be able to rotate to the opposite side. So this is the reason why we really need to be able to needle that particular area at the Huatuojiaji. And just to reiterate what Brian just said, the Huatuojiaji you'll feel is more of a hole. It's more pliable, whereas you actually go to the opposite side. And again, you have to palpate fairly deep. You feel more of the rigidity of that myofascial tissue. It feels more sinewy with that. So that's one way of looking at it. In the module 1, we actually do a lot of manual muscle testing to be able to show where that is. And also the next slide that Brian's going to get into is a motion palpation for the thoracic vertebra.
Mm-hmm. Yeah, so to use this bottom illustration, if it's shortened in these deep paraspinals, those are going to be pulling the spinous process and pulling that vertebra. If we looked at it from the back, the spinous process would be going to the left, but that would be a right rotation. And then if this other one is pulling to the other direction, that's going to be locking that facet joint and kind of creating that torquing. So what you're going to feel is that rigidity on one side and more pliable on the other side.
And then one more thing, I'm sorry, Brian.
Sure.
So when you have that vertebral fixation, instead of the vertebrae, which normally will move independently of each other and then collectively into flexion, extension, lateral flexion, is that segment now becomes locked and moves as one section. Mm-hmm. So therefore, you can have decreased nerve output coming from that vertebral section. And the longer that vertebral fixation lasts, it can lead to degenerative processes as well and spondylosis.
All right. Yeah, so just reiterating that shortened is keeping it torqued to the side. And then that lengthened side is kind of struggling to maintain that position of the vertebra, and it gets overpowered. Mm-hmm. So again, that shortening one is actually giving a decreased signal back to the nervous system. It's almost like it's just stuck and it just turns off. It doesn't turn off its function, but it turns off its communication. Whereas the lengthened side is trying to let the nervous system know that it's really struggling, needs a little help. Mm-hmm. All right, another way of assessing for vertebral fixations is with a motion testing. So with this, you have to sink into the lamina with the thumb. Let's say it's on the left side of the spinous process. So you're really at the Huatuojiaji points. It's at the left side of the spinous process at T8, and then the right side at T9, and you push towards the midline. So you're testing to see if there's movement between T8 and T9. And then you could switch to the thumbs and test again. If the vertebra is moving properly, it should move in both directions. In this one that's illustrated here. And then imagine the thumbs in the other position and you're pushing back the other way. That there's movement in both of those directions. Now, there's not going to be a ton of movement. It's a subtle movement, but you should be able to feel play. That there's a little movement back and forth in either of those directions. Mm-hmm. And if there's movement in one direction and not in the other direction, or sometimes even no movement in both directions, that's indicative of a vertebral fixation. Mm-hmm. All right. So this is a really good way to assess for, really give a much more precise assessment for the fixations. Matt, I think you're going to take it from here, yeah?
Yeah, okay. So with vertebral fixations, that can be a contributor to normal degenerative changes of the spine, spondylosis, which occurs with aging. So let's take a look at this x-ray. You can see at the very bottom, you've got the sacrum, and then you've got your L5. Now look at the disc space between L5 and S1 compared to L4 onto L5, and even L3 onto L4. So you see a much larger disc space. You see a nice open, clear intervertebral foramen at L3 there, also between L4 and L5. But it's cloudy, the intervertebral foramen between L5 and S1. Brian, can you be able to show that L5, S1? Yeah, the intervertebral foramen.
Oh, yeah, got it, okay.
There you go. So see how cloudy that is compared to above L3, L4. So this is where the spinal nerve is exiting, right? So then now let's take a look at the organ systems. Let's go all the way up to T11, the very top. You can see how the disc space is narrowed there. At T12, the disc space is narrowed there. Even L1 onto L2, it looks like the disc space is narrowed there. Same with the intervertebral foramen. So in this particular case, I would suspect that this patient would have weak kidney pulses, maybe some adrenal fatigue, possibly some urinary bladder problems. They could have thoracolumbar junction syndrome is one possibility with this. Now, I would also suspect that T11, T12, L1, or maybe T10 on T11 and T12 would be a vertebral fixation, which would be contributing further to the spondylosis and the degeneration cycle itself. Now, because the disc is going to be narrowed, it's not going to be carrying its weight, so therefore there's going to be a lot more force transmission onto the facet joints, and also a contributor to creating a vertebral fixation. All right, so let's go back to the anatomy, a netter image there on the left, if we would. So we saw that Brian was talking about T8, T9, T10. Let's kind of go through a little case scenario here. So let's say that the vertebrae in netter there, that vertebral body, let's say that's going to be T8, the one below that's going to be T9, and then you've got T10. You've got a patient coming in with, let's say, liver type of symptomologies. Let's say they drink a venti coffee from Starbucks in the morning, and then in the evening, after a long day of work, which they don't like their boss very much, they feel trapped. They drink a bottle of wine at night. So they have a lot of things in their life that are contributing to a liver yin deficiency, a liver blood deficiency, liver qi stagnation. So in this case, the liver itself could be angry, let's say, could be slightly pathological. Maybe it shows up into a blood test, or maybe not. Maybe it's the stages before that. That sends then messages to the sympathetic ganglion at the innervating spinal segment around T7, T8, T9, which will then be reflected into the tissues of the Huatuojiaji points, the inner bladder line, and also the outer bladder line, in addition to the front mu point. So what you'll commonly see when you start to have reactions of spondylosis and organ symptomology is chi edema at the Huatuojiaji points. Can we go to the next slide? All right, now this is going to be in the low back, but you've probably have already felt this before many times with patients, is that when you're palpating the dumai or just at the Huatuojiaji points and it feels spongy compared to maybe 3 or 4 segments above, or 2 to 3 segments above or below, it feels kind of like there's water retention within that area. Well, we can call that trophodema, which is Western medicine way of saying it. We can also call it chi edema because that's actually a pathology in TCM. Now, the chi edema is going to be from an underlying chi and blood stagnation that's going to be offsetting the waterways. So therefore, another way of looking at this, so when you have spondylosis, that's affecting the dorsal primary nerve, which is then affecting the vascularity. So therefore, you're not moving the water in that area as easily. So water then starts to accumulate within those tissues, a la trophodema or chi edema. Now, needling this with also moxibustion, next slide, please. Needling this with moxibustion definitely changes the chi edema within that treatment. Now, you can also use chi edema as a prognosis. So let's say, for example, the first treatment, there's quite a bit of chi edema there. You needle it, seems like it's feeling a lot better. The next time that they come in, you want to measure that chi edema and see if it is 25% less or 40% less. You can even take a photo of the pitting edema the first visit and compare it to the second one. When the chi edema starts to become less and less and less, the patient is usually getting a lot better. So you can actually use that as a sign. Moxibustion with on the needle is actually really great. You can also just do indirect moxa, but the combination between the needling and also moxibustion is going to be really useful. All right, so let's go into the next slide. Let's talk about facilitated segments. Now, facilitated segments is so very much TCM. It's big in the osteopathic world, and it has been for decades. The facilitated segments is basically talking about the relationship between the spinal cord, the viscera, and the myofascial tissues, especially the deep paraspinal muscles. Now, for example, that liver case that we were just talking about previously, if the liver itself is going to be pathological, has liver qi stagnation, but maybe a tense pulse, signs and symptoms that we know of liver qi stagnation or liver yin deficiency, liver blood deficiency, and the person also has different aspects in their life that help to support that diagnosis. The liver could be sending messages back through that sympathetic ganglion, which will then affect the myofascial tissues. So you've got the Huatuojiaji points, the myofascial tissues, you've got the liver itself. Now, if those myofascial tissues start to become shortened and tight, that can cause a vertebral fixation. As that vertebral fixation becomes more chronic, there's just this perpetuating cycle between the deep paraspinal muscles, the organ itself, and the myofascial tissues. So let's go to the next slide. Now, which structure becomes facilitated first is difficult to specify because the spinal nerve root, the viscera, and the myofascia send disruptive messages to each other along the neural pathways because they all communicate. And when pathology exists in one area, all tissues associated with the neural pathway will be affected. This is not unlike the TCM theory of organ and channel relationships where pathology in one ultimately affects the other. Now, facilitated segments are often associated with spinal offsets. You'll see this frequently, spondylosis, and also neuropathy. What I mean by neuropathy is affecting the dorsal primary nerve and also the anterior segment, which will be innervating the front mu point. All right, so the next slide. So when an organ and its innervating spinal segment become facilitated, diagnostic points on the trunk, such as we talked about, the front mu point and the back shu point, as well as the Huatuojiaji points, will become tender. So that's going to be your facilitated segment, but this is also where TCM comes in. Let's look at this quote from the Miraculous Pivot in chapter 13. The 12 regular meridians connect with organs, Zang Fu, internally and with the joints, limbs, and other superficial tissues of the body. When the ache is located in the organ, the meridian is ill and as a result becomes painful. So therefore, when you have organ-related disharmony, then reflected within its channel, that would also be under, let's say, facilitated segments. This is why we'd want to be able to treat the Huatuojiaji point, the back shu point, the outer bladder line, the front mu point, and also to go ahead and give quite a bit of herbs and also different acupuncture points to be able to break this perpetuating cycle of facilitated segments. Let's go to the next slide. This is going to be a patient of mine. Her chief complaints were vertex headaches with premenstrual tension, and then also a chronic adductor strain, part of the liver channel. Now, she was a high stress case. She was working as a personal trainer within the gym. Drinking 6 to 8 cups of coffee was not a big deal for her at all. And she was also the bottle of wine at night. She loved her shaoyasan, loved it, bought it by the case. Pale and red papilla, dry coat with her for sure, tense and edginess to it, and slippery pulse. So the tense, it would come up and hit your finger like an angry liver. Now, for those people that have studied with us before, she's had a right elevated ilium. So a right elevated ilium, as we saw earlier in this presentation, can be able to create a side bend, and that side bend will often come to that middle jaw region where the liver and gallbladder are. Right, so this is what she had. She also had an asymmetrical hip shift to the right. For those people that took module 2 would be able to understand that. And that helps to confirm also an elevated ilium and the reason why she had a chronic adductor strain. Now, what's interesting about this is we're treating the Huatuojiaji points, the back shu points, the outer bladder line, the front mu point, treating her with herbs, treating with exercises to be able to open up that vertebral fixation. And she got substantially better. Her adductor got substantially better as well because we're treating the liver channel. There was also another case that I wanted to bring up is that one of our students, Eric Isaacman, who's in Portland, Oregon, he's a C.SMA. He graduated a few years ago. And he applied these techniques with a patient of his that was having horrible vomiting and nausea, diagnosis gastroparesis, and he was able to change her condition when so many other doctors were really struggling trying to be able to help her. And he was able to change her condition substantially within a few visits. She was then able to tolerate the herbs, and she was doing fantastic. In fact, she did so well with this application that the doctor, her doctor, wanted to know what Eric's contact information was, and now he's kind of the gastroparesis person in Portland, Oregon, which is kind of funny. So let's go into the needling then, Brian.
Mm-hmm.
All right, so when you're feeling the Huatuojiaji points in the cervical and thoracic regions, like Brian was talking about, you can be able to palpate the excess and deficiencies. So the excess going 1.25 to 1.5 inches is not a problem whatsoever with most patients. You want to get it down to those deep paraspinal muscles. Now, some patients, when you're trying to be able to get that needle in and it's already getting plenty of chi, stop, right? The deep needling is not going to be for everyone. Stop, respect that person's chi. And then the other needle that's going to go more superficial, you're going in just about 1/2 to 3/4 of an inch, more of a reinforcing needle technique, whereas the deeper needle is going to be a reducing needle technique. Now, if somebody came in that had this liver chi pathology that we were just talking about, my goal would be to get that deeper needle as close to the bone as possible so that I know I am affecting those transversal spinalis muscle groups innervated by the dorsal primary rami. And if I was only able to get it in 3/4 of an inch or maybe 1 inch or so because the person felt a lot of chi, continue with your treatment, continue treating the different points, and then go back to that particular segment. 9 times out of 10, you're able to go in a little bit deeper each time with that, and they may not even know it, or they start to feel a little bit different sensation. So the goal with this, it really does make or break a treatment getting in to those deeper areas with the Huatuojiaji point when you diagnose it as excess. And then here's the directions for the lumbar region, your excess and deficiencies as well. Because the lumbar region is so much deeper, going in with a 3-inch needle is going to be really important with most patients. And then the next slide. And then if you find excess on both sides, then you can go in 1 to 2.5 inches, even farther, 1.5 inches, depending on the size of the patient. In the thoracic region, double check, please, that you are 0.5 sun away from the lower border of the spinous process and you're not 1 sun. So needling 1 sun is going to be for a specific conditions in other places like in the lower cervical and the lower lumbar for facet joint problems. When we're treating the organs, let's make sure we are 1/2 inch, 1/2 sun away from the lower border of the spinous process. Perpendicular needle insertion, if we go oblique, and this is just my own opinion with this, is that going in oblique is that you may miss some of these wonderful innervations from the dorsal primary rami by missing the actual tree of the dorsal primary rami, where it actually inserts into, when I say tree, it's actually more of the roots of a tree where it goes in, innervates all of that tissue of the Huatuojiaji point. So a perpendicular needle insertion we find to be much more effective than oblique. Brian, I think, or Jeffrey, the movie is next, but Brian, do you have anything to add in that area before we go into the movie?
No, I mean, just the oblique, I think people do for safety reasons, but if you have the measurement down and it's 0.5 sun, I mean, it's protected by the lamina.
Mm-hmm.
So it's as Matt was mentioning, for these conditions, especially in the thoracic region, you want that 0.5 sun. And there are specific reasons in the lumbar or cervical why you might use the 1 sun. But even in the thoracic region, if you're at the 0.5 sun measurement, it's very safe.
Okay.
And you'll see that in coming up video. But before the video plays, Matt, I think we have one more screen here. Are you done with this slide?
Yes.
Yeah. So it's just to pay attention to your surroundings, you know, and also, you know, some people might be disturbed by cadaver images. It's a pretty easy one to watch because it's such a zoomed in section and it's not particularly bothersome. But do be aware that we're about to play a cadaver image, and more important, be aware of your surroundings. Mm-hmm. So fortunately, well, not fortunately, but with COVID, you're probably not watching this at Starbucks or something like that. But if you are in a public place, just be mindful that there is about to be a cadaver video. And also no sharing of this video. It's part of the donor program that we have sort of rules for that. So just respect the information, but don't share the video, and also be mindful of your surroundings. All right. Are we ready for the video?
Sounds good.
Wondering if I need to minimize.
This video features a non-chemically treated cadaver specimen prepared by the faculty
No,
of
Brian,
the
you're
Sports
good.
Medicine and Acupuncture Certification Program for Module 1, the spinal column. It is a detailed dissection of the region of the Huatuojiaji Points at the level of T9. Before getting to the cadaver video, let's take a moment to review the relevant anatomy. The Huatuojiaji Points are located 0.5 to 1 sun from the midline on the posterior aspect of the body. For the thoracic region, it is imperative for safety that the 0.5 sun measurement is used, as a greater distance from the midline increases the risk of causing a pneumothorax, especially with deeper perpendicular needling. The Huatuojiaji Points are also motor points. Depending on the depth, motor points of different muscles are reached. The most superficial motor points reached are that of the spinalis, which is the most medial of the erector spinae muscle group. The deeper motor points reached are the multifidi, part of the transversospinalis muscle group. This group is frequently referred to as the deep paraspinals. This video specifically examines the Huatuojiaji point at the level of T9, starting with the skin and progressing layer by layer through the subcutaneous fat, the lower trapezius, the spinalis thoracis, the deep paraspinals, and ending at the lamina. The video shows the layers in succession and potential safe needling depth for patients. However, we do not advocate deep needling for every condition, and assessment of the points in the patients must be considered for safety and efficacy. In some situations, a more superficial needle insertion is suggested. In other situations, a deeper insertion is desirable. Palpating for excess and deficiency, along with other findings, will inform needle technique and depth. At AcuSport Education, we teach proper needling technique and depth for the Huatuojiaji points based on clinical efficacy, patient safety, and patient comfort. A thorough understanding of the various layers is vital for proper needling. Let's now look at these layers on a non-chemically treated cadaver specimen.
All right, so with a deeper needling of Huatuojiaji point at T9, let's look at the layers that will be penetrating. Okay, so we've already gone over subcutaneous, there's the skin, subcutaneous fat. Then we have the posterior aspect here at T9. This would be the lower trapezius. This tissue here would be the latissimus dorsi, so we pull that back, retract it back. Then the next tissue that the needle will be going through at the Huatuojiaji will be the erector spinae. So if we take the erector spinae, we retract that back, we go through the erector spinae, the needle would then, with deeper penetration, go into the deep paraspinal muscles, which lie directly on top of the lamina. So the deep needle of Huatuojiaji point, if it did go to the bone, it would go to the lamina. So let's take these deep paraspinal muscles off so we can show the bone. So continuing with the anatomy of the Huatuojiaji, as we've discussed, we've got the skin, we've got the subcutaneous tissue, we've got the lower trapezius, peeling that away.
The latissimus dorsi, we peel that away. The needle of the Huatuojiaji point at T9 is not going to affect the latissimus dorsi. We're just moving it out of the way so we can see. Now the deeper layer, we've got the erector spinae. So the needle will be going through the erector spinae as well. We retract that back. Okay, so then now, as you can see, here's the deep paraspinal muscle that covers the lamina, the deep paraspinals. And if we retract this back, retract that back, now this gray tissue that you can see right there, that's going to be the vertebra. So this would be the lamina. So the acupuncture needle would be hitting the lamina with a deep insertion. So 0.5 sun away from the spinous process of T9, needling all the way down to the bone, it would be hitting this region right here at the lamina. So let's go ahead and put these tissues back. And the Huatuojiaji points going directly into a deep needling would then, I can feel it now, tapping on the lamina right there. Now you can see how deep I am at the T9, 0.5 sun away, is that the needle on the bone is almost to the coil, and this is an 1.5 inch needle.
All right, thanks, Jeff. All right, Brian, you want to go to the next slide?
Sure. So, oops, I have to get the screen back up. Tell me if the PowerPoint comes back up. Is that?
Yep.
Yep. Okay, cool.
Awesome. Okay. All right. So again, just to reiterate. So your Huatuojiaji needling can be deep on the excess side, more superficial on the deficient side, or if you feel like both sides need a deep needle, in addition to maybe a do-my needle, going all the way close to the bone to affect that transversus spinalis muscle group innervated by the dorsoprimary rami. Now, link the Huatuojiaji points then with your back shu point and your outer bladder channel point, because then you're getting a stimulation between the medial branch of the dorsoprimary rami, the lateral branches of the dorsoprimary rami, in addition to the front mu point. Now, yin-yang therapy is a classic TCM needle technique, which combining the back shu point with the front mu point, our modification is just to add those Huatuojiaji points in addition to the outer bladder line point if it is tender. Make sure you're also treating your front mu point as well to get that signaling with the anterior rami, the posterior rami, and also the sympathetic ganglion. All right, so then next, I think I'm handing this over to Brian because we're going to talk about he's going to talk about a myofascial release technique, which are really very useful. One of the many myofascial release techniques that we teach that are really quite useful for helping to align the vertebrae after your needling. Brian?
Yeah, and this is fortunately a very simple technique to do. The patient's going to be sitting on a bench. You'll see in the video, I have this really nice custom-made bench that I use, which is great. You can change the height and all. It's really nice. But you can take two folding chairs and put them together with the backs facing away. So the two seats are kind of pushed up against each other. That would work fine. Really, any seat would work. You could use a treatment table, but you want it to be low enough to where the patient has their feet on the floor because they want a real stable base with the feet. So with that, you're going to sink into the tissue. They can push a little back against their feet so that they're giving a little bit of resistance. And then they're going to start going into flexion. You'll see this all in the video, so I'll just let the video play. But you kind of have an image of it here, and really great to follow after the treatment of the Huatuojiaji points. So why don't we go ahead and play the video? Oh, I think I need to minimize again.
Looks like we're good, Brian.
So we'll be doing a technique where we're spreading down the urinary bladder jingjin, especially focusing on the erector spinae muscle group. This is a really nice technique to do for many instances, but especially after working with the Huatuojiaji points and working with vertebral fixations, if they're spinal offsets, because we're taking the patient into a sagittal plane movement. And that length created in the spine as they're rolling forward, especially if it's a functional type scoliosis, will start to straighten the vertebra as we're going through the erector spinae and loosening up any areas where the erector spinae are bunched. Right, so you can do this with both hands simultaneous or one hand at a time. Both hands is nice, but sometimes it's good to guide the patient by working on one side while you're guiding them. It depends on their ability to do this well. First thing they're going to do is make sure they're solid in their feet. They can even give a little teeny push back into their feet so that they can support the weight that I'm pushing in, kind of balance the weight. Now the head goes. And she's just pulling me through the erector spinae, so I'm lengthening. I'm looking for balance movement. Let the left shoulder go a little bit more. There we go, that's good. So with men, you can just go straight down. With women, you might have to readjust. Stop for a moment there, have them stop the movement, sink in before they start going into flexion. There you go. Now, as they go into flexion, you're spreading through the erector spinae. Arms relax. Okay, hold. I'm just going to bring this up for a second. Hold upright for a moment. So I want to sink in, push back against me with the feet. There we go. Good. And now keep on going forward. Let that left shoulder go a little bit more. There we go. Good. All right, now you can help them as they stack. So behind settles first, a little bit more weight here. There we go. A little bit more. A little bit more. There we go. A lot of people want to come instantly up with the head. I'm going to do this incorrectly for a second. A lot of people want to start coming up here first, but we want them to stack first to get the support. Stack, chest up, and they're in a neutral position. I should mention that the full video, that was a little edited for time. The full video is on our YouTube channel. This was a video we just did recently for the upcoming Module 1, which covers vertebral fixations and the Huatuojiaji Points. And the full video, then you have access. It's a little a preview, I guess. You have access on our YouTube channel.
Which is sportsmedicineacupuncture.com. It's in the contact slide at the very end of this presentation. All right, cool. There's a few exercises that we threw in that we teach in our postural assessment and corrective exercise class, or PACE, that are really very useful to prescribe to the patient after you've treated them with your Huatuojiaji needling and everything else that you do, just to help to reinforce everything that you've done, try to be able to keep the excess and deficiency away and keep the transverse spinalis muscles pulling more evenly. So the cat-cow exercise, the next slide, which would be your bird dog exercise. And then the next slide, which would be, I believe, what's the next one that we put in? Your prone press-up exercise. So your step-by-steps are right there in your slides. It'd be great for you guys to be able to practice these yourself before you actually practice them on a patient. They're pretty easy step-by-step in order to be able to do that. I think the next slide is going to be our last one. We've already gone over an hour, Brian. Boy, you and I can be able to talk, right? So let's look at this gentleman that had the stomach heat, the spleen chi deficiency, and the gallbladder heat. So before the treatment, you could see those spinal offsets, the spinal bends, where the spinal bend is coming into the midline, where you know that's going to be that usually a vertebral fixation or a subluxation there. Again, match that area with the person's signs and symptoms so you can really address that. And then after the exercises and the treatment, you can see that his elevated ilium is much better, which then helps with those side bends. And he's going to be getting more qi and blood moving through that dumai as well into the Huatuojiaji points, as well as getting more of the qi, the trophic factor, going into those organs. So that is our presentation. Brian, is there anything that you want to finish up with on that one?
Well, just a reminder that the references are there, but also we have the YouTube channel and the Facebook. We have a couple of Facebook groups. Anyone's welcome to join those. Sports Acupuncture is a general group. So a lot of discussion happens there. Sports Medicine Acupuncture is the official Facebook page for Acusport, but that has a little bit more of the class information, advertisements, upcoming classes, that kind of stuff. Anyone can post on the Sports Acupuncture, on the Sports Medicine Acupuncture. It's you can respond and comment on any post, but you can't start a post. So,
if you like our education, we'd love to be able to see you in any of the online webinars. We're also going to have recordings that are going to be available through LASA OMS. The Sports Medicine Acupuncture textbook is also available through LASA OMS. You can tell that Brian and I have been around each other for quite a long time. We play off each other quite a bit, and we really have a passion for this medicine. And that just comes out with our work. And so hopefully this was useful for you. Again, thank you very much to LASA OMS. And we can spend, at least I can spend another 15 minutes or so on any questions that people may have. Brian, do you have time?
Yeah, I'm available.
Awesome.
I guess I should stop the sharing.
And actually, Brian, really quick, before I start asking the questions, can you go to your settings and just double check and see if the output and input are both your microphone? Because I feel like your computer is picking up, your computer microphone is picking us up.
Okay.
And while you do that, let me just ask the first question because I don't want to waste our 15 minutes. Let's go back to kind of the beginning of the webinar. So what would some of the indications be at the apex of the concave and the convex?
Well, it depends on where that apex is landing. So where the apex of that side bend would land, let's say, is it going to be in the upper jowl? Is it going to be in the middle jowl? Would it be more around a T12, L1 region? Then you would start looking for any kind of signs and symptoms that may be occurring with this particular patient. Let's say, for example, the person's coming in with low back pain, and they have an elevated ilium. They've got a side bend that then leads right up to L1 and T12. You feel their pulses, and the kidney pulse is really quite low. Let's say it's a male. They have low libido. Maybe their knees hurt a little bit. So a lot of different signs and symptoms that are leading you toward kidney qi deficiency, kidney yin deficiency, kidney yang deficiency. And you see that then in that side bend. Make sure you're treating those Huatuojiaji points, usually in segments of 3. The reason why we're treating in segments of 3, and I forgot to say this with that transverse spinalis discussion, is that because the multifidus and the semispinalis capitis are spanning usually 3 to 6 vertebra, by treating your Huatuojiaji in segments of 3, you're really starting to cover your bases with that. I hope that answers your question.
All right, well, let's go to the next one. Could you speak to the risk of pneumothorax with some of the needling techniques and any measures you recommend to mitigate this risk?
Brian, do you want to take that one, or you want me to?
I guess we both can. Hey, the sound's better now. I don't hear the echo.
It is. I didn't want to interrupt you during the lecture because you guys were just flowing, and I thought it might kind of slow things down.
I could definitely hear it, but I didn't know what to do to change it. Yeah. So, well, now there is a little bit of an echo. Yeah. Oh well. If you have the measurement down at 0.5 sun, you're very protected by bone. It's not an issue, with maybe a caveat of somebody had very severe scoliosis. I don't mean just minor scoliosis, but very severe scoliosis. I saw some research at one point that there was a high likelihood, or at least crossover of clinicians palpating what they think are the spinous processes in severe scoliotic patients, and they were actually palpating the transverse processes. So in that case, you're at the transverse process, what feels like a spinous process because of such a severe scoliosis, and you go 0.5 sun from that on one side. Going one side is going to be okay, but if it's the right transverse process and you go 0.5 sun to the right of that, thinking you're in the lamina, you would have more of a risk of causing a pneumothorax. So if a patient had severe scoliosis,
severe,
yeah, I'm going to be much more cautious because I'm uncertain. I don't know. I don't exactly know what I'm palpating because there's so much twisting. But that's a severe case.
99% of your patients, 999 out of 1,000 patients, by going 0.5 Sun from the lower border of the spinous process, you're going to be safe. Double, triple check your measurement. So make sure you're from the lower border of the spinous process at the intervertebral, right between the two spinous processes, and then just go 0.5 Sun and you should be totally safe.
Quick question about the program, actually. So Gina would like to know, she just has her acupuncture board to take, and she plans on taking the next couple of months, and she wants to sign up for the SMAC program. Would you recommend that she sign up now or wait until after she passes her boards?
She can sign up now. Right now, with COVID, has really thrown us for a loop. We stopped in March of 2019 when we were in New Jersey. We finished Module 1 and Module 2 in New Jersey. We're going to start Module 3 live in person in New Jersey in November. So that is something that we can be able to look forward to, which is great. Now, within the next 2 weeks, we will have Module 3, 75% of Module 3 will be available online through L.A.C. OMS. So you could actually look at that recording, and that would actually count toward the certification. And then what you would do is then come to the live in-person injury class. This is where we put it all together. We're actually watching you needle. We have mentors. We have assistants. We're making sure that the quality control is in those live persons. Now, you can take individual classes as CEUs, and you don't have to sign up for the certification program. You don't have to do the whole thing at all. You can just take individual classes, which some people do.
Just to clarify, each module has multiple classes. So what Matt's mentioning, some of the classes we were able to transition into webinars, like some of the class that treats the sinew channels and does a lot of myofascial release. We have that's getting ready to go live for Module 3. The anatomy palpation cadaver lab, that's going to be going live for Module 3. So you have the option to do some of those classes on webinar. But the class where there's a lot of specific acupuncture needle techniques, some of which really need oversight, then those will be coming up at a later date.
Perfect. Next question is about moxa. So why did you suggest indirect moxa use? Will direct moxa application work as well?
Yeah, absolutely. Absolutely. I like having needle moxa because through the conduction of the needle is fantastic. You can also go ahead and do rice grain, or I prefer a little bit bigger cone, more of a popcorn kernel, unpopped, that size, actually putting onto that area. That works really well. If you want to do indirect, just for the timing of it, that works as well, as long as you can be able to see the change of the color of the skin.
All right. Let's see, next question. Could you speak to the progression of pathology of the spine when treatment of this sort is significantly less effective?
When treatment of the spine, can you repeat that again?
Yeah,
of course. Could you speak to the progression of pathology of the spine when treatment of this sort is significantly less effective?
Treatment of this sort is significantly less effective.
I'm not understanding. Brian, you want to take that?
I'm not exactly sure what, about the question, but I think saying that if this isn't the right approach, I think I'd say it a little differently, is that this is a approach. It's not the only thing you can do. I mean, obviously people might need to address nutrition, a whole bunch of things, but this is going to have an effect. If you have an effect on the spine, it's going to have an effect on the segment, the spinal segment, which is going to have an effect on the sympathetic ganglia. If you're working through that thoracic and the upper lumbar region, it's going to have an effect on the organs. Is it going to be enough to solve all the problems? No, I mean, you can still look at nutrition, you can still look at a range of things, but I think that this will be, you'll find that it's applicable and helpful for some people a ton. For some people it's the thing, you know, but for others it's part of the picture.
Yeah, this treatment method and this application is just one application that you would be using in your treatment protocol. You could be using gua sha, cupping, nutrition, as Brian was talking about, qigong exercises, a number of different things, putting the whole thing together using traditional Chinese medicine thinking. This is just one very effective technique to use for a lot of the patients.
Yeah, and also, I don't know if this was, hopefully it was clear from the lecture, we were talking about that segmental aspect and how using Huatuos and addressing the vertebral fixations is part of the picture. That doesn't mean you would only be treating that. You'd also be treating distal points and looking at constitutional aspects and a whole bunch of, I mean, this is part of the whole.
Mm-hmm. Mm-hmm.
All right. Are you guys okay to do a couple more questions?
Sure.
All right. Next one. Any specific cautions regarding Huatuo of the cervical?
No, they're actually safer than the thoracic region. Mm-hmm. They can be more difficult to needle, especially if the person has a large chest, depending on where the face cradle is, if they have a lot of extension when the person is laying prone. In that case, you would want to either lower the cradle just a little bit to patient comfort or to put a pillow underneath the chest so you're decreasing that extension within the cervical spine. That's a lot easier to be able to get into the Huatuojiaji points there. You know, again, the lower cervical region is going to be pretty taut with a lot of people. So when you're needling the Huatuojiaji points, if the person's getting plenty of chi within a ½ inch, 3/4 of an inch, but you do want to go into that inch, 1.25 to the cervical region, needle other points first and then come back to it. Usually it's going to be a lot easier to go back and get a little bit deeper with that particular point. I hope that helps.
Do you guys use electro, and any thoughts on that?
Yeah, this is a big discussion that we've had. Michael Cordino is a good friend of ours. I've known Michael for about over 20 years, and he's got neuropuncture. I don't use electricity that much. I will use it in certain cases of excess. I prefer more of what needle technique can be able to do to not only the local region, but also the adjacent and distal regions. I don't use electricity on the Huatuojiaji points. Needling deeply and with certain particular needle techniques, you can get really good stimulation. And I know that some people use electricity on the Huatuojiaji points, and that's totally fine for their own practice. This is just my own opinion and how I treat. Brian?
Yeah, I don't use a ton of e-stim or electrical stimulation either, but I know a lot of graduates from the program do. So I mean, it's definitely something that is, you know, you can take and add to it. But I'm with Matt. I kind of like the manual stimulation of the needle, and I think a lot can be done with the manual stimulation. I think it kind of calls on the body to, you know, if you need to stimulate and wake up, it kind of calls on the body to recognize that signal, and I think there's something very powerful about that. But it does require more needle technique.
All right. How about 2 more questions?
Sure.
All right. Can you speak about accessing points on people that have had a fusion?
Okay, Brian, you want to go or you want me to go?
You can start.
Treat it the same way. Treat it the exact same way, because they're still going to have a dorsal primary rami. So treat it the exact same way as fusion or no fusion.
Yeah. Now you're not going to get the movement, right? The motion test is going to.
No. But I would actually probably increase my Huatuojiajis from segments of 3 to maybe segments of 6, depending on how big the fusion is. Even bars in the spine, you know, that are holding up the spine, they're still going to have dorsal primary rami, so they're still going to be under influence of treating the Huatuojiaji points. Absolutely.
Yeah, and I think those segments can kind of go to sleep because they don't have to moderate that movement in the spine, so they can kind of become a little deadened, both from the surgery and from the lack of movement. So I think it's that stimulation is super important.
When there's a decrease of proprioception, there's deficient chi.
Yeah.
Right.
All right. Our last question. Often in needling in the cervicals, I feel crunchy, striated tissue in the needle. Would I consider this to be excess shortened tissue?
Brian, you want to start with that, or I can comment on it?
Yeah, I don't know. I think it depends on the situation. It doesn't jump out at anything to me.
Yeah, it does, because you can still have crunchy tissue, dried out myofascial tissue that is going to be also deficient as you go deeper. So I wouldn't use that particular diagnosis on the needle tension. with that as being excess or deficient with that particular case.
Well, I cannot thank you guys enough for this incredibly amazing webinar. I mean, I know everybody enjoyed everything that you guys had to say, and I know we are in talks of doing another one, so everyone stay tuned. We will have these guys back for another show. Do you guys have anything you want to say to the audience before we go for the night?
Thank you very much for attending. Really appreciate it. If you have any questions whatsoever, don't hesitate to contact us. Our contact information is going to be on the PowerPoint, and we'll get that PDF to Jeff. I get that to you tonight or tomorrow morning, Jeff.
Perfect. I'll share that on our blog right away, and that'll be the notes for the webinar along with the webinar recording. Again, all of you will get this recording in 5 minutes by email. Also, check out the different classes that Matt has upcoming. So in June, there are some online recorded classes happening, and then in November, in-person starts back up at Eastern School in New Jersey, so please don't miss that. And next week, we will actually be doing another webinar, so check your emails for the registration for that, and I hope everybody has a wonderful evening.
Thank you, Lasso MS.
Yeah,
you can go to, thank you, Brian. It's always good hanging out with you, buddy.
You too.
Well, thank you, Matt. Thank you, Brian. This was wonderful.
All right, thanks,
Good
you
night.
guys. Take care. Bye-bye.
Bye-bye.